questions in the chat, and Laura will, I think we would like to save the questions till the end, unless Laura's comfortable with stopping her presentation in the middle and answering the questions. But Laura, I guess that's up to you how you would like to proceed with the questions. Now, to introduce our presenter today, Laura PALMA received her Master of Science degree in Genetic Counselling from the University of Toronto in 2005 and joined the Division of Medical Genetics at the McGill University Health Center in Montreal. Shortly after graduation, where she remains today, she is certified by both the American Board of Genetic Counselors and the Canadian Association of Genetic Counselors. Laura has over 18 years of clinical experience counseling patients and families at risk for a variety of hereditary cancer and neoplasia syndromes, both in the adult and pediatric settings. She is an assistant professor in the McGill Department of Human Genetics and is actively involved in teaching, clinical research, and supervision of genetic counseling students. Laura has contributed to the development and implementation of mainstreaming genetic testing for a variety of tumor types at her hospital institution. Her research interests are in the areas of hereditary cancer, biomedical ethics, and alternative models of genetic service delivery to improve access to cancer genetic testing. And thank you, Laura, for coming, and the floor is yours.
All right, thank you. Good evening, everybody. Just going to share my screen quickly. Right. Do you see it in presentation mode? Mm-hmm. Okay, perfect. So thank you for the introduction, and thank you to the organizers for inviting me here. I'll explain at the end of the presentation how a genetic counselor from Montreal was invited to speak to you all tonight. So the broad title that I was given is genetic testing for you, and I clarified with the organizers my specific subspecialty of genetics, because genetics is a very broad subspecialty of medicine, and within genetics there are many subspecialties. So pediatric genetics, neurogenetics, ocular genetics, metabolic genetics, etc., etc. So my area of specialization is in the area of hereditary cancer. So our discussion tonight will center on genetic testing in the context of a personal or family history of cancer. There are definitely overlapping themes that I'll talk about, which would apply to, genetic testing for Huntington's disease or neurodegenerative conditions or cardiovascular disease and things like that. But the focus will really be on hereditary cancer risk, because that is what I have worked in specifically for the last almost 20 years. So I don't want to make the talk too quote unquote sciencey, but it is helpful, I find, for students and for the general public to understand a little bit of what I call cancer epidemiology. So we all know cancer is common. We all know someone who's gone through a diagnosis of cancer, but how do we, in terms of a risk assessment, tease out those risk factors, those that might be genetic and those that might be non-genetic, and really determine who are the best people to offer genetic testing to? As you'll see, most cancers are not hereditary, thankfully. And what do we mean by the genetic basis of cancer? So we'll go through that a little bit. And things that we look for in a personal, medical, or family history. So some red flags that you might think about if you've heard about genetic testing or have been thinking about it yourself or know someone that's gone through the process. And then we'll sort of go through the nuts and bolts of, what that process looks like and what the testing can and can tell you in terms of outcome of results. So I'm sure most of these statistics are known to you, but cancer is very common in Canada and a leading cause of death in both men and women. And this is a busy table, but across the top, it tells us what the lifetime probability of developing cancer is in intervals of 10 years. And along the side, you'll see from most common to least common cancers in males and females. And so this is just to make the point of when do most cancers occur in the general population? So if we look at something like colon cancer in a male, if you go across that column, you'll see that by the age of 50, less than 0.5% of men will have developed a colon cancer. So not very common. But as you get older, now you're looking in the 70 to 79, 80 plus age group, that risk starts to really increase over the age of 60 for a lifetime risk in the range of 7 to 8%. So colon cancer is one of those classic cancers that is really a disease of aging, much, much more common in older people, which means that if we see it in a 40-year-old, as you'll see in the presentation, this is a red flag. If we use breast cancer as the same analogy in a female, you can see that by age 50, and age is even more skewed in colon cancer, but in breast cancer, if you add 0.4 and 1.4, by age 50, about 2% of women will have breast cancer before their natural menopause. But we know the population risk of breast cancer is about 1 in 8 women will get it over their lifetime. So when do most of those breast cancers happen? Well, after menopause, usually 60s, 70s, and 80s. So when my mother got breast cancer and she turned 70 and all of the individuals she worked with were developing cancer, she thought, was it the schools we were in, or is there something in our environment? Is there this, is there that? And I explained to her mother, it's your age group. You are now in the age group where unfortunately these things are going to be occurring. And it doesn't mean that there's something affecting your region or your place of work prior to retirement. So keep in mind that cancer is more common as we get older. So luckily, most of those cancers happen after the age of 50, and cancer in children is not very common. Of course, in the pediatric setting, when I see a child with cancer, in many cases, genetic testing will be indicated at young ages. But if we think of the most common cancers in men and women, prostate being the most common in men, breast in women, and then in non-smokers, colorectal cancer would be the next most common cancer, which interestingly we hear much less about in terms of when you hear public campaigns and screening campaigns and things like that. But it is a leading cause of cancer-related deaths in Quebec. It's a really big problem, actually, early detection of colorectal cancer. So when we think of common risk factors, we've talked about increasing age. What about other risk factors? So dietary or lifestyle factors. So for example, let's use colon cancer for the example. Again, there are very well-studied risk factors actually in terms of how much whole grains you eat, how much water you drink, whether you consume enough fiber, whether you consume enough cruciferous dark vegetables, how sedentary you are. We know that BMI and obesity can be linked indirectly to colorectal cancer risk. So it's one of the cancers that does have quite a large lifestyle component, I would say. If we think of smoking, we always associate smoking with lung cancer, but smoking also increases the risk for esophageal cancer, gastric cancer, kidney cancer. Hormonal factors come into play when we think about things like breast cancer. And I would put reproductive factors in there as well. So not only did a female take oral contraceptive pills or hormone replacement, but did she have children? At what age did she have her first child? At what age did she start to menstruate? At what age did she go into menopause? All those factors that would modify the overall lifetime of exposure of estrogen, for example. And then there's some environmental exposure. So you look at incidence of melanoma in places like Australia, New Zealand, for example. We know UV radiation in those parts of the world is a big risk factor. There are certain viruses like HPV and cervical cancer. And then the piece that we're going to focus on tonight is the genetic risk factors. So some of these, as we said, are modifiable and some are not. Hopefully we'll all be lucky enough to grow old. We do see differences in terms of ethnicity as well, and where you live in the world. For example, like gastric cancer rates in Asia are not the same as they are in North America. If we compare rates of skin cancer in people of Scottish descent who have a very specific coloring, less melanin in their skin, much higher than African Americans, for example. Chronic medical conditions can come into play as well. So, for example, we know inflammatory bowel disease. So if you have a personal history of Crohn's or colitis, that is a significant risk factor for colon cancer. And so sometimes we'll have a referral in genetics for a young 35-year-old who's developed colon cancer in the context of, having Crohn's for 20 years. And it doesn't mean we say, oh, it's the Crohn's and there's no need for a genetic workup. But if all of our genetic testing does not yield a hereditary explanation, for sure that inflammatory bowel disease, it would probably be the major risk factor in that case. And then there are some chromosomal anomalies. So the chromosomes are the structures in our cells that package our genes, and some individuals have differences in the chromosome number. So trisomy 21 or Down syndrome is an example of that. And we know in Down syndrome, we see increased risk of leukemia, for example. Some of the modifiable risk factors we've talked about and I think are more or less self-explanatory. So maybe show of hands, or I don't know. You can use your raise hand icon. Who thinks that this statement is true? Broadly speaking, all cancer is genetic.
A good portion of it. I wouldn't say all.
Okay. So I would say more or less that is an accurate statement, but I'll parse that out a bit. So cancer is common, as we've just demonstrated. And when we think about it, the biology of cancer, what makes a cell divide in a way it shouldn't, invade parts of the body where it's not meant to be. And that's because the machinery of the cell essentially breaks down. The DNA has acquired changes over time that's given that cell an advantage in the body and allowed that cell to divide in a way it normally shouldn't. So that process is genetic at the cellular level. But that doesn't mean that those changes in that cell implicate all the cells of the body. And so when we talk about hereditary cancer, we're not talking about acquired changes or our cells accumulating a lot of junk as we get older, but really inherited changes in genes that exist in every single cell of our body. And that piece is actually only about 5 to 10% of all cancers. Interestingly, the mechanism by which a cancer develops, whether it's sporadic or hereditary, is pretty much the same. So our bodies are made up of trillions and trillions of cells. And most of our cells, not all of them, we wish we could make new neurons and reverse neurodegenerative changes, but dividing cells, hair cells, skin cells, the cells that line our bowel, etc., divide. And in order to divide, they need to copy all of their genetic information so that each cell is genetically identical to what we call its daughter cell. And that process over time can create an accumulation of errors in the cells. And it's through that process and through aging that cancer then can occur later on in life as we accumulate errors in our DNA. And essentially what we mean by a genetic mutation, you may have heard that term before. Increasingly, we use the term pathogenic variant, but we're talking about essentially a spelling mistake in a gene. So this schematic shows a chromosome unwound, and you see the strand of DNA. And all of our DNA, the genetic alphabet, essentially has only 4 letters, G, C, A, and T, and they pair together with a partner. G pairs with C, A pairs with T, and we know for all of our 20,000 genes exactly what that code should look like. And so a mutation or a variant in a gene means that there's a difference in the order of those letters. Sometimes it could be the whole gene is missing. Sometimes it could be a chapter in the gene is missing, what we call an exon. Or sometimes it could be literally a single letter change that introduces a stop signal, and the gene is no longer read after that point. And so changes that are inherited in the context of hereditary cancer occur in the same way as changes we acquire over time. So it's essentially the same mechanism of errors in the DNA code. Now, the timing of those errors determines whether a cancer can be inherited or not, or the predisposition inherited. So on the right side, you see the column that says later somatic mutations. So soma is a Latin term referring to body. So we're talking about mutations in the body, and you'll see on the top, you have a sperm in the egg. So the mutation has not been passed on from a parent. And at conception, now the embryo is growing, dividing, and there's no mutation present at the point of embryonal development. And now you have a human being who acquires a change in a cell, in a gene over their lifetime. And that's what we call somatic mutation. And that is the mechanism by which the vast majority of cancers occur in the general population. You could say by no fault of your own, but we've talked about some risk factors that might increase your chance of acquiring or accumulating gene mutations in your cells, but ultimately these are chance events, okay? Those gene mutations are spontaneous. They do not affect the gametes or the egg or the sperm. So this is not a risk you pass on to your children. It's really specific to a part of your body where that cancer cell has started to divide. Sometimes those changes can happen not at conception, but a little bit later, at the point of the embryo developing. And this is what we call mosaicism. This is a little bit of an exaggerated schematic, just showing one affected arm. But we now know with our current genetic testing technology, we used to think all the cells are identical. But now we know that sometimes we identify a mutation in the gene that's only present in a proportion of the cells and not all of them. And this is what we call mosaicism. So this can make counseling pretty challenging because the couple or the individual wants to know, well, can I pass this on? Is this mutation in my egg or my sperm? And the answer is we often don't know. And usually we only see features of that particular condition in certain parts of the body. It tends to be a milder presentation overall than if all the cells were affected. And then the germline mutations, which is what I focus on in my practice, are really those inherited gene mutations. In most cases, the gene mutation has been passed on through dad, through the egg, or through mom, through the sperm at the time of, through dad, through the sperm, and through mom, through the egg, at the time of conception. And so it's present in that first cell, which then divides into 2 cells, 4 cells, a developing embryo, etc. And now that mutation is present in all the cells of the body, including the gametes. And that is the reason why an inherited cancer gene mutation can be passed on to a subsequent generation. Now, most of the conditions we see in the clinic follow what we call a dominant inheritance pattern. So what that means is for that particular gene, and for all of our genes, in fact, we have about 20,000 genes, and they come in pairs because we get 1 copy from mom and 1 copy from dad. And in this example, it's the father who carries the mutated cancer predisposing gene, and on one of the 2 copies indicated with the white square, and the partner does not carry that cancer predisposing gene mutation, so 2 normal copies. So each time this couple have a child, there's a 50-50 chance that dad would pass on the non-working copy to either a son or a daughter, and a 50-50 chance he would. This presentation, I won't focus on specific genes and specific cancer risk, but suffice to say, depending on the gene, a gene could carry, a 10 to 15, 20% risk of cancer in some cases, all the way up to 100% risk of cancer over a person's lifetime. So we test for many, many different genes associated with many, many different levels of risk. Okay, so I think I've given you the answer for this one already, but so approximately what % of all cancers are hereditary? Do you think it's more than half, about 5 to 10%, or less than 1%?
5 to 10%, I would say.
That is the point. You're paying attention. I love it. Okay. So about 5 to 10%. So that means most cancers are of that sporadic type. And we've talked about all the risk factors that might contribute to sporadic cancers in the general population. Intermediate to hereditary and sporadic We have a proportion of families, we say there's familiar, what we call multifactorial risk, which basically means we do see more cancer in that family than we would expect by chance alone. Usually we see a more horizontal distribution, so a few siblings who have the same type of cancer, so 2 or 3 sisters with breast cancer in their 60s and 70s. And it's a fair question to say, oh, wow, that's a lot of breast cancer in that family. What's going on? But in these families, if genetic testing is indicated, we tend to often not find a single causative gene. So we tend to see an older age of diagnosis, clustering on one side of the family, but the transmission is very flat. Parents are unaffected, grandparents are unaffected, and their children are unaffected. So we share a lot more with our siblings than just half of our genes. We have a common upbringing, just up into a particular age, a common diet up into a particular age. Some of us pursue the same occupation. If smoking is all around us in our family, maybe there are a number of smokers in the same family. So there can be multifactorial causes for the same type of cancer. I saw a family recently where there are 4 cases of mesothelioma, which is a type of lung cancer that you get. Most people think of asbestos exposure, but there are also genetic causes of mesothelioma. So teasing that out, well, they all grew up in the same part of Montreal in a house that was 100 years old. Is it asbestos or is it genetics? Is it a combination of the two? So these are the things we sort of try to tease out. So what are some of those red flags, so to speak? So we said cancer is common and most cancers occur as we get older. So what would be a sign of a hereditary cancer? Well, the opposite, that cancer occurring at a younger than expected age. So premenopausal breast cancer, like we said, colon cancer happening in the 30s or 40s, or at age 18, for example, at ages that this type of cancer would not be expected otherwise. Not all cancers are created equally, so we know that specific subtypes of breast cancer are more likely to be hereditary than others. One in particular is called triple negative, which is not a hormonally dependent type of breast cancer, so it's negative for estrogen, progesterone, and a third marker called HER2. And about 15% of triple negative breast cancers are hereditary compared to the 5 to 10% of non-triple negative. We know that high-grade ovarian cancers are quite genetic. 1 in 5 are associated with an inherited gene mutation. And we know this from years and years of research. It's not just a best guess. This is based on studying thousands of people undergoing testing over the last 20 years. And we know that if we tend to see patterns, now family size is getting smaller. I have 1 child and I heard that that's the most common composition of the modern family in Canada right now, which when you're in Quebec and you're taking family history of large French Canadian families, is quite striking when the average sibship is between 7 and 15 people. So the types of patterns that we look for in a family history in the clinic might be more difficult to spot moving forward because family size is smaller. And so you're not going to see 3, 4, 10 cases of breast cancer occurring with ovarian cancer, et cetera, et cetera. What if someone just had a boy or they only had a brother? So we really have to keep that in mind in terms of our genetic testing approach moving forward. We'll miss too many people if we rely on these sort of old rules. But generally speaking, if we see combinations of cancer, like a woman with breast cancer whose brother has died of pancreatic cancer, or a woman with breast cancer whose mom died of ovarian cancer, these are sort of common patterns that would really signal a need for a genetic assessment. So I wanted to show a few family trees just to give you a sense of the importance of relationship with respect to family history. So for those of you who are not familiar with pedigree nomenclature, a circle indicates a biological female, and a square indicates a biological male, and the shading in just indicates a diagnosis of cancer. I've kept it simple. I haven't even put the age of diagnosis in these examples, okay? So this woman has come in or been referred because both of her parents have had a diagnosis of colon cancer. So raise your hand if you think this individual is at increased risk for colon cancer. I think it's pretty obvious, right?
Mm.
The question from a genetics perspective is she at increased risk to have a genetic predisposition to colon cancer, which is a very different question. And the answer is, I'm not sure. Why? Because the referral information tells us that her parents are not related. They're not consanguineous. They're not first cousins. And there seems to be no colon cancer history on mom's family or related cancers, and no colon cancer history in dad's family or related cancers. And we just said colon cancer in non-smokers is the second most common cancer in the general population. So it's very bad luck that both parents have the same type of cancers. But genetically speaking, the chance that one parent and their family or another parent and their family, evaluated independently, have a gene for colon cancer is actually very, very low. So this particular individual needs colonoscopy surveillance, but I don't think a genetic assessment is necessarily indicated in this case. Now, how does that compare to this scenario? So you have that same female whose mother had colon cancer, but now her brother, so the patient's maternal uncle, also has colon cancer. So now that history is affecting one side of the family, in genetically related individual. So now this is a more reasonable type of referral. Okay, you have two people in the same family. A genetic assessment may be indicated depending on their ages. Even more so would be this scenario, where now you have what looks like a vertical transmission. And we said genes are passed on from parent to child, from one generation to the next. And the fact that now it's the patient's brother who has colon cancer, as well as her mother, means probably the brother was much younger when he got that cancer. So if we're thinking about genetic risk in these scenarios, example C would probably have the highest, and example A would probably have the lowest, even though the individual in A says, I have two first-degree relatives with colon cancer. I need to see genetics. But really, when you piece it out, the risk of colon cancer versus the risk of an underlying genetic cause for colon cancer are two very different questions. Hopefully that's clear. Cancer type matters as well. So we talked about specific types of cancer that are more likely to be genetic than others. And so, you know, you don't need to be a geneticist, but I think the family tree on the right with 3 cases of breast cancer would be striking to most people, even physicians, and say there must be something in that family. But as you'll notice, the average age is around late 50s. Our patient with breast cancer at age 55, her mother is unaffected, so there's sort of a missing link there. And we keep in mind that breast cancer affects 1 in 8 women. So having even 2 women with breast cancer in the same family is going to be increasingly more common. Versus the patient on the left, whose family history on the paternal side is less informative. She doesn't know as much information, but her mom died of a heart attack at 55. There's no other related cancers in the family to date. But if we compare these two, definitely the ovarian cancer has a much higher risk of a gene mutation than the woman with breast cancer at 55 who has a family history. And the reason for that is because ovarian cancer only affects about 1.5% of women over their lifetime. It's significantly less common than breast cancer. And there's kind of an inverse relationship between how common a disease is in the general population and how likely it is to be genetic. So a lot of people think the field of genetics is the field of rare disease, and that is true. And the same rule can be applied to cancer. So the rarer a cancer is, the more likely that if it occurs, there's a stronger genetic component to it. Some more signs of a hereditary predisposition in the family might be some rarer cancers. So breast cancer in a male, a rare cancer of the adrenal gland, which sits on top of both kidneys, called a pheochromocytoma. There's some cancers that we see in children where 50% or more are hereditary. When we see the same cancer occurring twice in a paired organ, so a woman gets breast cancer at age 40 and then 20 years later, not the same cancer comes back, but she gets a new breast cancer in her other breast. that's definitely a red flag. The same would be true for kidney cancer or any paired organ. Sometimes in the clinic, if we examine an individual, there are non-cancerous features that we associate with the cancer risk that we see in the family. And that could be anything from a person's head size to very specific facial features, to skin finding, to the presence of cysts in their jaws, and all kinds of unusual things that we might note on a physical exam that no one else would have thought about could be related to the cancer risk in the family. An absence of exposure, so I gave you the example of asbestos and mesothelioma. And Ashkenazi Jewish ancestry is an important one that I wanted to highlight, and I'll tell you in a minute. And this is very specific to the breast cancer genes, BRCA1 and BRCA2, which you may be familiar with if you followed the story of Angelina Jolie or Christina Applegate or Beyonce's father, or all these celebrities who've come out telling people that they've tested positive for these genes and the interventions that they've taken to reduce their risk. Mutations in BRCA1 and 2 are significantly more common if you are of Ashkenazi Jewish descent. We don't have perfect estimates of how common they are in the general population, but we think it's in the ballpark about 1 in 400 to 1 in 500 people. Nobody's ever done a study of going out, taking 1 million blood samples of people walking outside in Montreal and Toronto and screening them for BRCA1 and 2 and figuring out in an unselected population how common these variants are. But that's the rough estimate. But if you're Ashkenazi Jewish, that goes up to about 1 in 40. So what we know today is being Jewish and having breast cancer, whether you're male or female, or ovarian cancer, it doesn't matter what age you are, is enough of an indication for genetic testing. Okay, I think this is my last quiz of the night. True or false? Hereditary implies that there is a strong family history of cancer.
I don't know. Hereditary implies that there is a strong family history. Yes, I would say so.
You would say so? Okay. So
But
I mark this as false to make the point that the absence of family history does not rule out something being hereditary, like that example of the single case of ovarian cancer, or single rare tumor. So I think over the years, a lot of physicians have not referred young patients because they have no family history, and there can be many reasons why we don't see family history: the structure, the composition of the family, the sex of the individuals in the family, whether a gene could be masked through many males in the family, et cetera, et cetera. So absence is not evidence. So while most patients with a cancer predisposing gene mutation have a strong family history of cancer, that is not always the case.
Yeah.
And I think this one is pretty straightforward. I've hopefully demonstrated that the type of cancer and the age that cancer occurs does influence the likelihood of an underlying hereditary cause. So why do individuals come in to see us? And there are a variety of reasons. And who should be offered cancer genetic counseling and testing? And what does that process look like? So we'll go through some of these questions. So over the years, clinical genetic testing for cancer, the BRCA1/2 genes were mapped in the early 90s here at McGill, actually. So we've been doing clinical genetic testing for 30 years now. And historically, and still to some degree today, that always involved a large intake process of collecting medical and family history. At the time, we would collect records for every single case of cancer in the family. Our dossiers used to be like this, very labor intensive because the testing was very, very expensive. So we were very selective in terms of who we tested. We got a little bit more savvy, so we started to develop computer algorithms where we would put the history and the ages of certain individuals into a computer algorithm and would pump out an estimate of the likelihood of a gene mutation in that person or family. And we would have a threshold. and let's say it was 10%, above 10%, we would offer testing, below 10%, we would not offer testing. Now, increasingly, there are conversations about, well, let's just get on with it and just test everybody. We're not there yet in Canada, but these conversations are happening around the world, and studies are happening around the world as well, not just in America, in Europe and in the UK. And we might get to a point where we test every single person with breast cancer, irrespective of their age, or every person with colon cancer, irrespective of their age, which, you know, over one professional's lifetime is pretty insane, to be honest, because the gears of medicine turn very slowly. But things have rapidly evolved with personalized medicine in this particular area. So the net that we've casted in terms of who we test now is very, very different from when I started to practice almost 20 years ago. Angelina coming out, talking about her story, definitely had what those of us in the cancer genetics field have coined the Angelina effect. And we saw our referrals skyrocket after her her piece in the New York Times. Like most healthcare in Canada, there's no consensus across all provinces in terms of who should be tested and what are the criteria. It really differs a lot from province to province. I think the only thing in common between the provinces is that the wait times are very long because demand is very high. So in the bio intro, the term mainstreaming was used. And what that means is increasing efforts of genetics professionals to push, to almost be like consultants and push the testing into the oncology space, and to normalize genetic testing as part of routine oncology care. And so our role will be on the back end to counsel those patients who do test positive. So we're focusing on more of those high risk patients rather than the risk counseling that we've done up to this point, because we just can't meet the demand anymore. And we're not serving patients well if they have to wait 3 years to come in to see us.
Right.
Generally speaking, we rely on, you know, published data and research to guide us in terms of the type of individuals we should test and what genes we should test them for. The standard of care is to test an individual with cancer. That does not mean we don't see in the clinic individuals without cancer who are concerned about their family history. But if we identify in the family tree a very good candidate for testing who is alive and has had a cancer diagnosis, and we think is the most informative person to test, sometimes the process will involve that individual. Sometimes the person coming in to see us, everyone who's had a cancer has passed away. And so we have to make a judgment call at that time, you know, what's the role of genetic testing in this person's medical management. And thankfully in Quebec, although we have no provincial guidelines, that gives us a bit more flexibility. So from a minus, we get a plus because we can test unaffected people if we feel that it's reasonable to do so. I'll talk a little bit about private pay testing a little later in terms of if you don't qualify by ministry guidelines, do you have other options? And the answer is yes. In Ontario, I don't practice in Ontario, but obviously I have many colleagues who do. There have been ministry criteria for a long time. I just pulled some screenshots out for select indications, but last year a very large working group revised those criteria finally and published them in October. And so if you are ever interested in being tested or being referred, your doctor would have access to these criteria and would be very able to determine whether you meet criteria based on current guidelines in Ontario. So people come in to meet us for a variety of reasons. Like I said, some have been newly diagnosed and they want to know, is my cancer hereditary? Will it affect my children, et cetera, et cetera. Some themselves are not affected, but they have family cancer history. Some have been newly diagnosed, and the genetic test result is really going to guide surgical management. So do I have a breast cancer gene mutation? And if so, I'm not going to do lumpectomy, I'm going to do bilateral mastectomy. Because I know that if I do lumpectomy, because of that gene mutation, the risk I will have a new breast cancer in the future might be 40%. I don't want to live with that risk. So, so it's very much personalized, and increasingly chemotherapy as well. There are certain classes of drugs that if we know you have a germline mutation in a cancer predisposing gene, certain genes, certain types of chemotherapy will be more effective in your case. And conversely, some people who carry variants in other genes might actually do worse on certain types of chemotherapy. So we've now been able to sort of parse that out and give people the best treatment options based on the test results. And in the example of the family trees with colon cancer, occasionally we'll see patients just simply for guidance about what type of surveillance they should be having and how frequently. Of course, we go through the benefits and limitations of testing and potential results, which I'll review in a second. So pre-pandemic, most consultations were done in person. And we were flying patients. It's kind of crazy to think about it, but from Nunavut and Témiscamingue in northern Quebec. And then we realized this makes no sense. So in March 2020, like the rest of the world, we had to figure out a new way to work. We couldn't just shut down completely. And so we started seeing patients by phone. Many providers were developing health apps. We were doing video consultations, and that has existed till today. I'm presenting to you from my home, but I do my consultations from home as well. I still have an office at the hospital that I use a couple times a week, but it's very rare that we would drag a patient in person these days, pay for parking, and do these consultations in person unless there is a specific request made by that patient or a type of accommodation that is required. We can use translation services, everything we would do in person remotely. Patients absolutely love it. So most testing is done through a blood sample, but we can do it through saliva as well. And part of the consultation process is essentially determining, are you a candidate for testing? And if so, are we thinking of one very specific diagnosis in your case, in which we're going to offer you a very narrow test for maybe one or a couple of genes? Or I was on the phone today with a patient of mine who's been diagnosed with a third cancer, and he's not even 40. And so we're going to go very broad and look at hundreds of genes. We don't know what's happening in his case. So that's sort of part of the process of figuring out what type of test. It's not a one size fits all type of decision. Why? Because the results of genetic testing are not yes or no. It's not like a glucose test or a cholesterol test where you have a normal range and you're either within the normal range or outside the normal range. Remember, those genes are made up of thousands of letters, and we're analyzing little spelling mistakes in all those letters. So a positive result is when we identify what we call a pathogenic variant or mutation, or what we call something that's what we say clinically actionable. So the laboratory is able to say with certainty, we found this mistake in this gene, we know what it means, and we know it impacts how this gene works. And if we're doing a large panel of genes, sometimes we can get a positive result, but it's in a gene that doesn't necessarily explain why that person got the cancer. So a person has breast cancer and we found a thyroid cancer gene. So it's somewhat incidental, but nonetheless actionable. The best case scenario is we found the cause for that person's cancer, and now we can provide risk counseling, not only for their treatment and management, but for the risk to other relatives. In between a positive and negative result, sometimes we get what's called a variant of uncertain significance. And this means that we found a spelling mistake in a gene that falls in kind of a gray zone. So the lab can't get off the fence. We all carry variants in our DNA, otherwise we'd be clones of one another, okay? So that's normal variation, and variants do not necessarily equate to genetic disease. And some variants, they're just not able to say whether or not this would affect how this gene works. It's never been seen before. It's not in laboratory databases anywhere in the world. It's not in a part of the gene we understand, et cetera, et cetera. So we can't act on those variants, and we certainly don't want to test relatives and cause undue harm because we don't know what it means to have a variant of uncertain significance or not. So we kind of set those results aside and wait for more information from the lab. And then a negative result, which is the vast majority of people undergoing genetic testing, means we've looked at a number of genes linked to the type of cancer of interest, and we have found no changes in those genes, no variants, no mutations. So in that individual and family, the cause of cancer predisposition remains unknown. So you might say, oh, we're still at square one. But we've ruled out a lot of things. So secondary cancer risks, we can modify risk for relatives. So a negative result, a lot of people say it's uninformative, but I think a lot of information can be gained from a negative result in terms of things you've ruled out. So people ask, can anybody be tested? And I told you that provincially it varies in terms of eligibility, but motivated individuals who want to be tested, even if they're actually deemed to be low risk, increasingly there are private pay options in Canada. And these are usually offered through providers that have an integrated genetic counseling service within the lab, or a commercial labs based in the US, or specifically private genetic counseling services that will counsel you and provide you with options about whether genetic testing is reasonable in your case. So, so technically, you can access this testing outside of the healthcare plan. Things to keep in mind if you're considering genetic testing, again, as we said, the vast majority of cancers are not hereditary. And when people come in to see us and we evaluate their family history and we determine that they're not a candidate for genetic testing, the risk in the family doesn't justify testing, this should be interpreted as good news. What we're saying is you're at a low genetic risk. We might focus more on the surveillance piece, but this shouldn't be seen as I'm missing out on something that I was hoping to get out of this assessment. We're saying the chance that you carry a gene for cancer is low. Conversely, the lower the risk the individual is, if they embark on testing, the chance that you will find variants you can't interpret is much higher. So this is a byproduct or a downside of genetic testing, if you like, that you can come out with more uncertainty than when you started with, particularly if the wrong people are being tested. If you're looking into a private pay test, I strongly encourage you to make sure to investigate whether genetic counseling services are included in that company's package in terms of explaining the results to you and things like that. Okay, my keyboard's getting tired. Consider your timingness and readiness for genetic testing, how you might react if you learn that you have a cancer predisposing gene mutation. We have patients involved in screening trials for cancer. So they sign up for a screening test, and as an adjunct to that screening test, they're given an option to provide a saliva sample to look at genes linked to that type of cancer. And they actually test positive. And then they're referred to us and we see them in the clinic, and this is really not information that they were expecting when they embarked on a trial in terms, for screening for endometrial cancer or ovarian cancer. So, be mindful of what you're signing yourself up for and prepared for potentially learning something that maybe you weren't expecting. If you're concerned about genetic privacy, which some people are, and might have misinformation about that, we do have legislation in Canada. It actually was voted in by the Supreme Court during the pandemic when nobody was paying attention in 2020. But you can look it up, Bill S-201. It essentially protects, it's a federal bill. It's a little bit tricky because obviously healthcare is a provincial jurisdiction, but it essentially protects Canadians in the context of genetic testing for predisposition to a disease. It essentially states that no employer or third-party insurer can demand you to pass a genetic test to determine your insurability or your employability, and cannot require you to divulge that information to them. So there is protection in Canada, finally, after many, many years where we had nothing. And lastly, this is the way Nina found me. So I was on this podcast, White Coat, Black Art, which is done by Brian Goldman and the CBC. You can find this on Spotify. You can find this on cbc.com. And they did a 2-part series on previvors. So these are individuals who carry a cancer predisposing gene mutation. They really delved into what it's like to have that sort of ticking time bomb, so to speak. And it's definitely more focused around breast cancer predisposition. And in my clinic, we see cancer predisposition of all types, not just breast cancer. But if you're interested in knowing, what that experience is like, it is a great 2-part series. I come in part 2, talking about the challenges of the system. It's a bit more depressing. And finally, Ruban Rose is affiliated with the Quebec Breast Cancer Foundation here in Quebec. Again, it's a breast cancer foundation, but they have an amazing video series that was done. It's in English and in French on many different topics about genetics, heredity, communication of genetic test results within a family, risk-reducing surgery that can be broadly applied. A lot of these topics, not just to breast cancer, but to any cancer predisposition syndrome. So you can Google Ruban Rose a genetic video series, and it will come up. So I think some of those are really helpful. I send my patients to that website all the time, and that's pretty much it. I think we have just under 10 minutes.
That was very good.
Anybody
Very
has
informative.
comments? Thank you. I'll just open the chat. Oh boy, okay. I don't know if somebody wants to moderate these, or should I just scroll down here?
Okay. So at this point, so we're going to take questions. There are a couple of questions that showed up into the chat. I'm going to stop the recording now.